Welcome to another episode of Cerebral Angio Reading Session. We have with us Jayshankar and Dr. Fasal. A short history, please.
Sir, this is a 61-year-old female patient who's a known diabetic with history of valvular heart disease and dyslipidemia, presented with complaints of left upper and lower limb weakness since 5 hours. Initially, she was taken to a local hospital where she was suspected of stroke, thrombolyzed with tenecteplase, and then later shifted here for further management. When we received the patient, she was conscious oriented. She had a power of 4 minus by 5 in left upper and lower limb with a NIHSS of 10. This is the CT and CT angio when she presented to the hospital. In the plain CT, it shows a right dense MCA sign, and in the CT angio, we can see a right MCA cutoff.
And there is a paucity of vessels in the corresponding area.
Yes, sir.
But what is the impression from this CT angio?
Good collaterals.
So probably the patient has got good collaterals.
Yes.
And the patient's deficit also is not that much. And the NIH score is 10. It's not a dense hemiplegia. So even though there is an M1 cutoff, probably the good collaterals is supporting the tissue, and that is why the patient's power has not deteriorated to grade 0. Now let us have a look at the angio first. Read the angio. This is
right femoral puncture.
So what do you think about the femoral puncture? This is the head of the femur.
Yes.
So this is the femur head.
Yes.
So you divide that into 3 parts. Usually the femoral artery will come somewhere between the junction of the middle 1/3 and the medial 1/3.
Yes.
And this is a normal bifurcation. It is not a high bifurcation. So you can see the bifurcation here. So this is the femoral artery is lying exactly over the femoral head. What is the advantage? What is the advantage of puncturing here?
So that to prevent hematoma, when
Hematoma,
we are giving
the
pressure,
main
we can
advantage
press
is
it against the head of
against a bone. So suppose if you puncture here, the two problems are: one, when you are pressing it, it is not pressing against a hard surface. So the chance of blood leaking is much higher. Second, if you puncture here, the chance of the patient developing a retroperitoneal hematoma is higher. If you puncture lower down, what is the problem? You will be entering a branch rather than the main artery. It will be dividing into 2 branches, and you might puncture the artery, but you will be puncturing the branch. So ideal location to puncture is in the main artery, femoral artery. And if you go by this diagram radiologically, you identify the femoral head. So the puncture should be at somewhere in the middle of the femoral head. Clear?
Yes.
So this is a clean puncture. So the chance of the patient having any complication is much lower in this. So what has to be done immediately after the puncture? After you have put in a sheath, the first thing to do is to take an angiogram and see if there is a small leak. If there is a small leak, immediately what you have to do is, you don't have to worry. Press the artery for maybe 1 or 2 minutes. Do a repeat angio. Why I am saying this is because if you neglect this and continue to do the procedure, the patient will develop a hematoma here, which will be difficult to manage. Whereas just by compressing for 1 minute, that can be taken care of. So always do an angiogram immediately after puncture and make sure that the vessel is normal. And the second advantage is you can see whether there is a loop, there is an occlusion, there is any abnormality in the vessel before you take the catheter out. So that this can be easily converted into the new machines into a roadmap, and under roadmap guidance you can take the vessel out. What next?
The diagnostic catheter was taken to the arch of aorta, and shoot was taken.
So the arch of aorta comes some like this. Understood. So what is this vessel?
Subclavian.
So this is not the subclavian. This is the subclavian.
Yes.
So this is the
Right.
brachiocephalic. Brachiocephalic trunk divides into
Common.
this is the common carotid and the right subclavian. And this vessel which is arising from here is the vertebral artery. So anatomy is clear. This is a straightforward vessel. The arch of aorta from which arises the right brachiocephalic trunk divides into the subclavian and the right common carotid, and from the right subclavian arises the right vertebral artery. Clear?
Yes.
Okay. Now we'll come to the next part.
This was the first shoot, sir.
So this is not a DSA. So you can see the skull bone.
Yes.
So it is in the new machines, it's very easy. You have to just press the DSA switch. You can convert into a. If you want to see the bony landmark, you can view this. If you want to cut off the bony landmarks, just view the DSA picture. So so this is the AP image and this is the lateral image. Always the carotid bifurcation is better seen on the lateral image, whereas the intracranial circulation is better seen. The MC is better seen on the AP image. So this is the digital subtraction angiography. So what is the angle in which you have to take the AP view? What is called a Townes view? Townes view is you have 15 cranial angulation so that the area of M1 will be clear of all the bones.
Yes, sir.
Clear? So this is not a Townes view. Townes view, the orbit will come much lower down so that the bony landmark will not overlap over the middle cerebral artery. Now read the angiogram.
On the right side, we can see the AP view angio. That is the internal carotid artery.
There is a loop here.
This loop here, and distal carotid also is almost normal.
It's a very straightforward, clean carotid, and then it divides into
Right M1 and A1.
A1, and A1 supplies.
Supplies both.
So here you can see one. This is the opposite ACA, and this is the ipsilateral ACA, and there is a anterior communicating artery somewhere here. So this carotid artery is supplying both the middle cerebral arteries. Understood? So what we can make out from this is the anterior communicating artery is patent, and you can see the opposite A1 also filling. And what you see here is
there is cut off
M1. Okay. And the lateral view, what do you see?
Carotid origin is.
So this is the common carotid artery, divides into external carotid artery and internal carotid artery. Okay.
There is a mild stenosis origin, but
There is very mild stenosis, probably around 30%. And what is this vessel which is going forward?
it is ophthalmic.
Ophthalmic artery. And what is this vessel which is going backwards?
That is PCOM.
It's a PCOM which is supplying, continuing as the PCA, fetal PCA. The patient underwent a mechanical thrombectomy by Solumbra technique, but we won't be discussing the details of this since this is an angio reading session. The patient had a good outcome and patient made a near total recovery. If you have any doubts or comments or suggestions regarding the angio reading sessions, please do let us know. See you next time with another episode of angio reading session. Thank you.